Good afternoon, everybody. My name is Sandro Galea. I have the privilege of serving as Dean of the Boston University School of Public Health. Distinguished guests, students, faculty, alumni, and friends, on behalf of our school, welcome to today's conversation, part one of our three-part discussion of anti-racism as health policy. Before we begin, I would like to say thank you to our co-host and partner on this three-part conversation, the Boston University Center for Anti-Racist Research. Thank you. Additionally, a thank you to Meredith Brown and Alicia Noel, and everyone else whose work made today possible. A few housekeeping notes before we begin. We'll be taking questions from the Q&A in Zoom. Additionally, we invite you to continue the conversation over the social media space. We'll be live tweeting this event via our Twitter handle @BUSPH. The event will be recorded and posted to our website. And if you had not done so already, we encourage you to register for part 2 tomorrow, featuring Representative Ayanna Pressley, and for part 3 on Wednesday, featuring Senator Elizabeth Warren, among many others. These public health conversations are meant as spaces where we can come together as a community to engage with the issues that matter most to health. Few such issues are as central to health as that of race. In public health, we have long known how racism has shaped health inequities in the US. During COVID, these inequities were painfully evident. We saw them over the past year in the disproportionate burden of sickness and mortality experienced by communities of color. But we also saw something else. We saw a conversation about racism, which accounts for its deep roots in our society and its effect on present-day health. Much of this conversation has been due to the work of Dr. Ibram Kendi, the director and founder of Boston University's Center for Antiracist Research. It has been a real privilege to work with Dr. Kendi on today's events. And now Dr. Kendi and I are going to talk a little bit about the intersection of race, data, and health during COVID-19, and otherwise start off the symposium. Ibram, Dr. Kendi, welcome.
Thank you, Dean. And I'm just excited that your School of Public Health, and our Center for Anti-Racist Research were able to come together and put together this important convening with these incredible scholars and leaders in the field.
Well, it's really been a privilege to get together. So the format here is we said we're going to ask each other questions. So I'm going to lead off. I'm going to ask you a question, and we'll take it from there. How's that? I thought we'd start with something foundational. I think thanks to your extraordinary scholarship, the concept of anti-racism has really entered the public conversation like never before. And when you and I first started conceiving of this gathering, we talked about doing something around anti-racist health policy. But I was wondering if you can actually frame that a little bit for the audience, really, since we're starting off these 3 days of conversation. What do you mean by anti-racist health policy? And perhaps equally as importantly, what do we want the world to take away from sort of the notion of anti-racist health policy?
Sure. So unfortunately, there are many different racial health disparities. And obviously, we're specifically going to be talking about COVID and the ways in which for the last year, we've seen that Black, Brown, and Indigenous peoples have been more likely than white Americans to be infected and killed. And of course, these disparities extend into other areas, from cancer to respiratory disease to heart disease and others. So the question becomes, why do these disparities exist? And anti-racist health policy presupposes that there's nothing behaviorally wrong with the group that's on the dying or the sick end of a particular racial health disparity, and that there's nothing culturally wrong. It also presupposes that there isn't necessarily a such thing as Black blood or white blood, and so therefore it presupposes that there's policies and practices in our society. There are conditions and structures and systems that are leading to these racial health disparities. And so anti-racist health policy seeks to replace those existing racist policies that are leading to those disparities. And these are policies that have been proven to reduce those racial health disparities if not eliminated. And what's striking though, Dean Galea, is that about this time last year, it was almost a surprise for people when the data started to come out that people of color were being infected and killed at higher rates. Even at the end of March of last year, even someone as powerful as the governor of New York was saying that this was the great equalizer. And so, I don't know if you could take yourself back to March of last year when all these leaders, Democrat and Republican, were calling this the great equalizer. What were you thinking then? And were you surprised when by April we saw these racial health disparities?
Well, I believe I could have the date slightly wrong. It was March 6th of 2020 when I wrote a piece that actually said that the burden of the virus was going to be felt disproportionately on communities of color and people who were socioeconomically disadvantaged. And I don't think I was saying anything that was surprising to me or to people in my circle. The people who I'm in scholarly conversation with, we could see this coming from a mile away, because it is the pattern that always happens, that when we have large scale social disruption, it is people who are marginalized and disadvantaged who bear the brunt of these forces. And I was actually going to ask you this, but let me just build off this for a second. I think one of the interesting elements of the moment is there's so much attention now, at least there's attention-ish to these issues, which of course was galvanized by COVID. But the core issues have been the same issues that were there 5 years ago, 10 years ago, 20 years ago. And when I have the privilege of being asked to speak, which I am sometimes, and asked to speak on these topics, I often say, I do my talk, and my first 2/3 of it, I never mention COVID. Then I pause and I say, notice I haven't said anything about COVID. So everything I've told you in this first 2/3 of my talk, which is 35 minutes, I could have told you 10 years ago had you invited me 10 years ago. Now let me talk a little bit about COVID. So I suppose my question to you is, in building a little bit on this, Dr. Kendi, is how do we not lose the moment? How do we, recognizing this, and I think it's okay. It's okay. People are paying attention now. That's fine. It's good. People are attention. But how do we keep attention so that it doesn't happen again? As you know, this is something I've been doing some thinking and writing about. So I'm curious about your thoughts on this.
Well, I think first, we have to unpack the narrative that emerged really at the end of April of last year, that to a certain extent persists, which is that, Black, Brown, Indigenous folks are dying at higher rates because they have more pre-existing conditions, and then stopping there, not asking why. And not actually even sort of talking about some of the studies that find that there are factors that are even more critical than even pre-existing conditions that explain, for instance, greater Black death, like lack of health insurance, like more likely to be an essential worker, and so on and so forth. And the reason why I think that that's critical, that we ask, okay, why? We don't just sort of stop there, is because when you leave it at, well, they're just more likely to have respiratory disease or this pre-existing condition, then people then assume that it's because they don't eat right. It's because, Black folks are not taking care of their health. So then it allows people to explain away the disparity based on the pathology of the people who are sick, meaning the behavioral pathology of the people who are sick or who are dying. And so I think we have to consistently ask that why. And then secondly, I actually think one of the greatest developments of this, and I was going to ask you how you, and how even scholars you've been in conversation with who've been working on these issues for quite some time have reflected on just the number of counties and even the number of people who have recognized that racism is that racism is a threat to our public health, and the way in which people are recognizing the relationship, the clear-eyed sort of relationship, and that we will continue to have a public health crisis on our hands so long as we have the crisis of racism on our hands. And so as you saw, in the most mainstream of ways, some of the most powerful and most prominent people, in this country making that connection, how did it feel, especially for those I'm sure that you've been working with who've been making that connection for quite some time? Did it feel as if you finally saw it, which America has been catching up to what the scholars have been saying for decades?
Yeah, well, I think it depends a little bit on your perspective, whether you glass half full, glass half empty. I try to be a pragmatic optimist, and but I do feel like, which leads me to say, okay, it took a while, but it's good. It's good. We're seeing it. It's good, and that's a step in the right direction. But I do feel like we're in a very interesting moment on that, aren't we? That we are that there is a very strong, very important current of progressive thinking that is shifting the Overton windows, which I've written about a little bit, which is the Overton window. The concept is the idea of, we discuss things within a particular window, and we shift that window, and it's named after Overton, who was the person who came up with that. And I think the progressive thinking shifts the window, which is really, really important. And I think from a certain perspective, though, that thinking also can breed impatience, which is, well, what's taking the world so long? And I feel that impatience as well. But at the same time, I'm tempered a little bit, perhaps by age, which is perhaps true, but also by feeling like the world takes a while to change. It's just reality that the world takes a while to change. And finding the space between saying, look, we're moving in the right direction. This is good. We should move faster, but at the same time, we need to bring everybody along, and that's hard to do. And trying to find the right space in that tension, I think, is a really important question at the moment. I'm actually curious how you grapple with that. I struggle with this a lot. I struggle with this. Am I not pushing enough? Am I pushing too much? Am I, how quickly can we move to make sure that we bring everybody along? And I spend a lot of time in my brain rummaging around trying to find the right balance.
Yeah, and I think for me, I'm constantly thinking about how to clarify the complexities of what we're trying to communicate, to express the alarm without sounding alarmist, provide clear sort of direction of what can be done, and also to really talk about the stakes. And so, and that's one thing I think what COVID has done, and at least what it seems to me is, I think COVID has demonstrated, like, unlike anything in the lifetimes, of the people living, is just how critical public health is. And I think for me, it really crystallized. I ended up writing a piece, I think, in the Atlantic last year in the midst of COVID, in which I wrote about, and I continuously have been returning to this, how for too long we've been living in a society really meant for slaveholders. And what I meant by that is, slaveholders created a sort of intellectual culture in which they had the freedom as individuals to enslave a community. And if we extend it out, it's just as you had individuals who wanted the freedom to infect the community. And so do not put any restrictions on me, do not invest in this place. And I think one of the things that I'm hoping that COVID provided for people is that, we saw so many people say, you know what, I want, the community needs freedom from infection, right? So forget what an individual sort of needs. We need a community sort of, we need the community to be free from infection, just as, Black folks were like, I'm not going to be free until the community is free. And I think people are realizing that they're not going to be healthy. We're not going to be safe from pandemics until we make the community safe. I don't know, what do you, I'm obviously not an expert on public health, but I think for whatever reason, people needed to recognize just how critical their own personal health is, how much the community's health bears on their own personal health.
So then this is something which I've thought a lot about and try to grapple with in some of my writing. So a couple of notes on this. Whenever I've written about that fundamentally health depends on the world around us. Fundamentally, health depends on policies and politics and law and money, on the places where we live, work, and play, and those set the conditions within which our health is generated. And one of the challenges to that often is this notion of freedom. And I often get the pushback. The pushback I get not frequently is, well, you're an immigrant, therefore you don't understand freedom in this country, which is, can leave that aside for another conversation. But I think we get mixed up on freedom because we mix up freedom from and freedom to. And when we talk freedom, we instinctively go freedom to. I have the freedom to do X. But we undervalue how much we actually care about the freedom from. And in this case, it's the freedom from unnecessary disease, for example. So I often use the example in my talks about when you get in your car, you actually get in your car with the freedom from expecting to die of that car accident, because we have reduced the death per vehicle mile driven from car accidents by 220-fold over the past century. So we have acquired the freedom from dying in our car. Now, to do that, we have sacrificed the freedom to drive in our car without wearing a seatbelt.
Yeah.
But today, in 2021, everybody would agree it's a freedom, maybe not everybody, but nearly everybody would agree that it's worth giving up the freedom to drive without a seatbelt to acquire the freedom from dying unnecessarily in our cars, right? And these are both equivalent freedoms. I mean, they're both important freedoms. And to my mind, once you understand that health is generated by the conditions under which we grow, where we live, and the conditions of our parents, our grandparents. And if wealth, to take a particular example, if wealth is a driver of health, my wealth is a function of my parents' wealth, which is a function of their parents' wealth. And if you come from a group of people that's been enslaved, they've never been able to accumulate wealth over time. As a result, you have less wealth. As a result, you have poor health. Once you understand that, you realize that actually we have to create the freedom for everybody to be freed from disease and to have health. And to do that, we need to make structural changes. So I suppose, and I'll turn it back over to you for another question. When I work through that logic in my mind, it's so self-evident. It's sort of, in some respects, it's so connected dots that my struggle is, how do we make that so clear? Like, when you hear some of the arguments which are pretty common these days, like, well, there is no structural racism. When you hear arguments like that, one pauses to say, well, what are we doing wrong in telling the story, right? Because when you and I can sort of have this conversation and says, well, it seems pretty obvious. We're obviously not doing a good enough job. I'll speak for myself. I'm not doing a good enough job of explaining it if in the larger conversation, what I see as obvious is not seen as obvious. So I guess the question is, how do we explain ourselves better?
Yeah, and so this is a tension for me, because on the one hand, I do think that there are people who are open-minded, who, if we explain it in a better way, if we use an analogy that really sort of sits with their experience, if we use terminology in which we meet them where they are, they will have a better understanding of it. And then I'm reminded that, like W.B. Du Bois, a Black scholar, wrote, I believe, a piece in 1935, I think in the crisis, in which he stated that he has described the facts of, let's say, the term we use now, systemic racism, by periodical, by speech, by book. And so there can be no denying that the American people know the facts of racism, but they still refuse, to eliminate this problem. And I'm saying that to say, I think there are unfortunately, there are forces in our society that know the facts themselves, but they simultaneously they have political or economic interests that do not align with the solution to that fact. And so then they use their platform to convince other Americans that, for instance, vaccines are bad for you, any number of sort of lies. And I think that's the challenge. Like, we're living in a moment of mass distrust and mass misinformation. And when you have the combination of those two, I think it makes it hard, because then there becomes no expert, right? So, anybody can just stand up and make a scientific claim, or a claim as if they're epidemiologists when they're not. And I think that's part of the larger sort of challenge that we're faced in. But I think it stems from distrust. And in other words, I think we've lived in a country, especially over the last 4 years, where that distrust has been sown and it's spread. And then we're constantly told to not trust those people who are different from us, who look different from us. When indeed, if there's anything COVID has shown, is that we have to come together or not. And one thing I'll say lastly about this, I was reading, as I normally do, on April 4th, King. And one of his most profound quotes, and I'm paraphrasing it, and I think it's really relevant, and I just wanted to get your sense of it to what we're talking about, is, King said something to the effect is that, we're either going to figure out a way to live together as brothers, or perish together as fools.
Mm-hmm. Yeah, it's a great quote, and it's this is why I'll tie this back to what we were saying earlier about COVID and about what COVID can teach us, right? Because in my teaching and in my writing and lecturing in the past, pre-COVID times, I often would use infectious disease as an example of why you cannot afford to neglect others if you care about your health. I often try to make the case, forget about moral argument. Let's just be selfish. Let's just take a selfish perspective. And you say, I care only about my health. And I often used infectious disease examples to say, well, if I care about my health, I actually care about you being vaccinated. Maybe not because I care about you at all, but just because if you're vaccinated, I'm less likely to get the infectious disease, right? And vice versa. So I used that example. Now COVID happened, right? And COVID was exactly that, right? COVID was exactly that example where all of a sudden we saw that if for you it's better for your health if I'm vaccinated and vice versa. So all of a sudden the interdependence of our health became clear. And in what I do, which is social epidemiology, there are good examples of that interdependence in non-communicable disease as well. But in communicable disease, infectious disease, it's so obvious, right? It's right in front of our face that it's hard to avoid it. And I think what we found when COVID hit is that we had not invested as a society in building the understanding that my health depends on your health and your health depends on my health. And I think this comes, to come back to King for a second. Reverend King has a lot of things he wrote about this, but I always found his invocation of compassion particularly important. I've written a bit about the difference between compassion and empathy, and compassion fundamentally is about recognizing our shared humanity and wanting to create a better world because it is what we should be doing. It is our role on the planet. I've always felt that matters much more than empathy, because empathy requires, well, I feel for you because I can put myself in your shoes. Well, I don't need to be able to put myself in your shoes. It is just the right thing to do that we create a better world for all of us. And in some respects, I think the COVID pandemic pushes us to that, right? It pushes us to say, yeah, we actually we actually need all of us to be healthy for one of us to be healthy. So I think, how do we keep that learning? How do we not forget that and keep this in our consciousness forever?
No, I agree. And I think to add to that, I think the challenge of this recognition of community and the recognition that we should be building, to use King's terms, a beloved community, is that there's been so much death, there's been so much pain, economic and certainly physical, and there's been so much suffering. And then there's been so many people with platforms telling the American people that the source of your pain are those Asian Americans. The source of your pain are those people who are not allowing you to have the freedom to not wear masks, or to not keep open your gym. And so we're at a moment in which we should be coming together, and I think many of us have, but then simultaneously other people are taking advantage of this moment to drive us apart. And I think that therein lies the challenge. And in a way, it's almost like two Americas are becoming ever more divided, in which some of us are recognizing our shared interest in being healthy, or to use, actually to call it intelligent self-interest. Like, I don't need you to be altruistic. I don't need you to be moral. All we need you to do is say, you know what, in order for me to be healthy, the community has to be healthy. And that's intelligent self-interest. But then others are like, well, if that person is healthy, then that means I'm going to be unhealthy, right? And so it's, this, and so I think therein lies the sort of problem. And I think, therein lies the challenge.
Well, this is, we could go on about this, we have 2 more minutes, but part of the challenge is we have brought upon ourselves in this country is because we have failed to see health as a public good. And a public good, by definition, is something that is shared, and it's not reduced by my health is not reduced by you having health, and vice versa. In fact, my health is enhanced, as we were discussing. So, and I think in part the commercialization and the reduction of health into essentially sick care has put us in a place where we no longer, we lost the vocabulary that says that health is improved by us all having health. And in part, I feel like our job is to bring that back into the conversation. I think these notions of public good and compassion are inextricable from what our shared agenda here is, because I think they sort of form the bedrock for saying you need an anti-racist health policy in order to create the structures that then generate health.
Precisely, and I'll say very quickly that, of course, this over the last year, many of us have been recognizing this sort of scourge of police violence, and obviously there's all sorts of economic inequality, but to me, at the basis of the problem of racism, if there is a basis, it's literally the number of people who are dying because of the color of their skin, because of the condition, because of the policies, because of our unwillingness to value their lives. And so when I think of even the term Black Lives Matter, I'm more and more connecting it to health and public health and what we have lost and what we continue to lose.
Dr. Kendi, what a privilege to have a conversation, to be your colleague. Thank you for everything you do. Thank you for engaging the way you do with us and with the world.
Thank you, Dean Galea.
Everybody, thank you for all these comments. And really, now it's my pleasure to introduce Kimberly Atkins. She's the senior opinion writer for the Boston Globe and will moderate today's panel. She'll also introduce our panelists. Kim.
Thank you so much, Dean Galea, and thanks to all of you for joining us today. First, before I introduce the presentations, I just want to let everyone know that I will have some time at the end of today's program to answer as many of your questions as I can. Please put those questions in the Q&A. Don't put them in the chat, put them in the Q&A, otherwise I might miss them. And so it is now my pleasure to introduce the first presentation today, which is called Children's Health Watch, the COVID crisis and racial, ethnic, and nativity-based inequities in economic hardships and the effect of COVID-related assistance policies. And the panel presenting that is Megan Sandel, Associate Professor of Pediatrics at Boston University School of Medicine, Kaye-Alese Green, Diversity and Inclusion Fellow at Boston University School of Medicine, and a Visiting Fellow at the Institute of Health Systems, Innovation and Policy, and Stephanie Ettinger de Cuba, the Executive Director of the Children's Health Watch.
Great. Thank you so much for having us today. We're excited to talk about the COVID crisis and the economic hardship inequities for immigrant families and families of color. And I'll be joined by Stephanie and Kaye-Alese. If you go to the next slide, for those that aren't familiar with Children's Health Watch, Children's Health Watch is a research policy network based at Boston Medical Center, but we actually collect data in 5 cities, in Boston, Baltimore, Philadelphia, Little Rock, and Minneapolis. And since our founding in 1998, we interview families in those cities in healthcare settings, families with young children, 0 to 4 years of age, because that's when you're growing your body and brain for the rest of your life. Over our 23 years, we've actually published over 70 peer-reviewed articles and over 100 policy publications. And if you go to the next slide, where we operate is thinking about both the downstream effects of the data that we're seeing from interviewing families, where we're seeing the interactions between common hardships, things like household food insecurity and child level food insecurity, reporting cutting back on the size of children's meals. Also housing instability, things like homelessness, moving frequently, having risks of being behind on rent or evictions. But then we're also looking at what are the upstream policies that actually caused the downstream data that we are seeing as interviews with families. And so we look at things like WIC and SNAP and other types of housing policies like housing subsidies or eviction prevention. And so if you go to the next slide, what we put into place with the Center for Anti-Racist Research Support is a survey where we had interviewed families before the COVID pandemic. And we now were able to put in a new survey in the field after and during the COVID pandemic, where we're able to look at some of the effects of both the hardship levels before and after, and also start to look at them by race and by immigrant status. And so I'm going to turn it over to Stephanie Etterjakuba to share some of our early preliminary results.
Thank you so much, Dr. Sandel. We're really excited to share some of our preliminary data with you today. This line graph is actually showing our comparison from those pre-COVID surveys with families with young children to the COVID period. And you can see there are really dramatic increases in hardships. The red line at the top is housing instability. Next one down, the purple line is household food insecurity. And they're at the bottom with a smaller increase, but still really important because, as Dr. Sandel said, this is a really severe hardship where most severe level of food insecurity among households with children of child food insecurity. But really interestingly, we actually saw a drop in the rate of evictions among our families. We think this may be related to the eviction moratoria that were put in place, and there's more for us to explore there. Go to the next slide. Great. So this chart is showing us the odds of household food insecurity overall for our whole sample, then also by maternal race and ethnicity. So the yellow bar is the pre-COVID time, and then the blue is the odds of household food insecurity. So for our sample overall, we saw that families were 57% more likely to be food insecure in the COVID period than they were pre-COVID. And definitely saw elevated odds for all of the different racial and ethnic groups. However, the only one that was significant was for families with a Latina mother. And in those families, the odds were more than, the families had more than twice the odds of being food insecure in the COVID period. Go to the next slide. And as Dr. Sandel noted, we're exploring both our analyses by race and ethnicity and also by nativity. So here we're actually looking by nativity. Again, the yellow is the pre-COVID period, and here we're looking at housing instability. So for our families and for our sample overall, the families were almost twice as likely to have housing instability in the COVID period as compared to the pre-COVID period. And among our US born families, they were also significantly more likely to be housing unstable. But I think what's most dramatic on this slide is our immigrant families, where we see they're almost 3 times as likely to be housing unstable in the COVID period. Go to the next one. So here's just the beginnings of our policy analysis, and this is where we're really headed with these analyses. So this is just the prevalence of benefit participation. We're looking in this study at participation in SNAP, receipt of stimulus payments, and also unemployment assistance. Those are the blue, orange, and green bars there. And this is looking again stratified by race and ethnicity. And I think overall, what's notable is that among all of the groups, between 85 to 95% of the families were receiving some kind of assistance. However, there are pretty big differences in exactly what kind of assistance they're using by or receiving by race and ethnicity. And that's where we're going next, and more to dig into there, especially to understand the why. We go to the next one. Thanks. So this is again looking at the same benefits, looking at SNAP and looking at our stimulus payments. What you see here is actually some more of this nuance that we're hoping to get to and looking at race and ethnicity and nativity. Here on the left, the purple bar is our US born families. Just 4% of our sample of US born families overall received no assistance, but almost a quarter of the immigrant families receive no assistance. So if you think about 1 in 4 children in the United States has at least one parent who's an immigrant, and then we have 1 in 4 of our young kids not getting any assistance, we're potentially talking about millions of young children. So that's really some of what we're be tackling next, is really understanding how the ways that the policies are set up, who are they deliberately and excluding by law, and then also just excluding by practice, how that then drives the household hardships that we've looked at on the prior slides. And so we'll look forward to sharing more with you in the future. But the goal really of this is to bring this to policymakers, but not only that. And so Kaye-Alese is going to tell you about not just what we're doing with policymakers, but also with medical education.
Hello, everyone. Thank you, Stephanie. So I am honored to round out this presentation for Children's Health Watch by talking about how we're going to utilize this data to train future physicians. Dr. Kendi and Dean Galea opened our conversation today up with the recognition that a community's health is directly a sign and impact on our individual health. And recognizing that as medical education has long stood in the position of treating the downstream impact of pathology, but often hasn't brought in the conversation about upstream impact. And so thinking about that and having the great privilege of being the Diversity and Inclusion Fellow at BUSM, and as a medical student, I am excited to be at a school that is sewing in social determinants of health into the curriculum. But I think this work from Children's Health Watch and of the other panelists today really will allow us to continue to push the envelope on how we can begin to teach upstream drivers of health, how physicians can be essentially sources of health equity, and begin to figure out where we can partner with policymakers, with structural aspects, and support the health of a community and support the health of individuals. And so to finalize what we've been talking about today is we believe that this research, this work, and all the work that is being done at the Center of Antiracist Research and all around BU can lead us to create a more equitable future. I'm sure many of you have seen a picture like this before, and we've talked about equity versus equality, but the thing we really loved about this slide is that last photo, that last panel on the right is, how can we begin to build common ground? How can we begin to sew in that we are creating structures and policies and helping people to practice just really living their lives through an anti-racist lens that levels the playing field for families and communities in Boston and then all around the country. And so on behalf of Children's Health Watch, I'd like to thank the Center for Anti-Racist Research for your support, as well as the School of Public Health for bringing us in today. Thank you again.
Thank you so much for that presentation. And our next presentation is Digital Redlining, Telehealth Inequities in Boston's Black and Latinx Communities. And that will be brought to you by Stephen A. Wilson, Chair of Family Medicine at Boston University School of Public Health, and J.K. Srinivasan, Research Associate Professor at Boston University Questrom School of Business.
Hello, good afternoon, everybody. Thank you for this opportunity to present this information to you. Before we go forward, we just want to recognize that we have a large interprofessional and multidisciplinary team working on this project. We have faculty from the schools of business, medicine, and public health, students from the medical school of business, anthropology, public health, family medicine, internal medicine physicians, medical anthropologists, a strong research coordinator and director, Boston HealthNet, and partners in community health centers. It's really takes a team to bring this information and put this project together. Next slide, please. Racism is part of the multifactorial etiology of health inequity and racial disparity, usually working below the surface, affecting us in surprising and unexpected ways. Disparities and structural inequities often evolve over time, and they sneak up on us, and we see them in the rearview mirror, and we kind of go, oh, how did that get there? Well, with COVID-19, forcing healthcare systems to change how they delivered healthcare. Some had some telehealth ideas that they were going to roll out in 1 year, 3 years, 5 years. And then when COVID happened, these rollouts happened in 1 month, 1 week, and sometimes 1 day. And so we saw with the rollout of telehealth, there were things that were starting to happen that were really underscoring and building on structural inequities and some of the racist structural inequities that existed before. And so this kind of led us to want to ask this question: how does structural racism affect the deployment and use of telehealth during COVID-19 pandemic in communities served by Boston Medical Center and affiliated community health centers? The idea was that when concrete is wet, so in the early stages of rolling out telehealth, it's shapeable and you can move it around. But once that concrete dries, it becomes set and it's firm. And then any sort of work you try to do with it becomes far more challenging. So the idea was to identify and address these health equities early on. Next slide, please. And so why did we need to make sure we had community partners in this? If you look at this slide, you'll see that out of every 1,000 people in a given month, less than 1 shows up in an academic medical center, and only about 8 are even hospitalized. But over 200 visit a doctor's office, and more than half of those actually visit a primary care physician's office. So it became very apparent to us and important that if we were going to do work that helped to address structural racism in this area, we were going to need to have some strong community health center partners. Next slide, please.
And to build on Stephen's point of telehealth has been a pretty dramatic disruption in terms of how health systems are organized, how they work. And the challenge for us is both understanding the lived experience of people going through this pretty dramatic disruption, but also looking at what does the health system actually see in terms of empirical data. Right, so the administrative data allows us to see who came in, who was seen, when they were seen, how they were seen. And that gives us a baseline against which we can look at what the lived experience looked like and what the health system to manage it. So the quantitative analysis, in a lot of ways, is not just looking at the data that BMC and the community health centers own, but supplementing that with additional information, what CDC puts out in terms of their social determinants, Massachusetts Economic Justice Index, what the Center for Antiracist Research has been doing with their COVID tracking project. All of these additional data sources, when we're able to integrate them, give us a holistic picture. So now you can look at the stories that people tell when we rolled out telehealth and what the data tell us. And that gives us a way to see the disruption in a much more rich and robust way. Going back to Stephen's earlier point is the concrete is still wet, so we get an opportunity to shape it. And when we started this project, one of the things we thought about was we thought that the technical infrastructure, right, the device or the bandwidth would be the primary challenge. And BMC was at the forefront thinking about the problem. So they asked every patient that called in whether they had a smartphone or if they had the required internet access to be able to use the device. And it turns out that 83% of our African-American Black patients have a device and have the internet access. It's higher with Hispanic patients and about the same with white patients. So the underlying technical infrastructure didn't seem to be the real problem. Now, there is an open question of what's happening with that 15 to 17% of patients that don't call in, and that'll come up in the policy recommendations. But the preliminary data analysis that we did highlights two very interesting patterns. Prior to COVID, non-English speakers rarely no-showed. I mean, if you compare the rate of no-shows for non-English speakers versus white patients, or English speakers, sorry, what you get is patients who are non-English speakers actually show up for their appointments at much higher rates than non-English speakers. With the pandemic, you start seeing this really interesting reversal in certain geographical areas, right, where non-English speaking patients actually no-show at higher rates than English speaking patients. And that brings up an issue of why that's happening, and that's something we're exploring further. The other disparity that's emerging is the stark difference in video use, right? There's about a third, there's only about 12% of non-English speakers who use video versus 35% of English speakers who use video. And the implications for these really come up in two broad areas. One is about unpacking access, and the other is really around advocacy for patients.
And so, as we continue to look at some of the quantitative and qualitative data, which we're still very actively collecting, besides the technology infrastructure that Dr. Srinivasan mentioned around who has access, we need to think about the bandwidth. And sure, the bandwidth is floating around everywhere, but is it financially accessible? And we had to look at technology literacy and fluency. Having a phone or having a smartphone doesn't automatically mean that you can interface with digital video capacity in order to do healthcare. So the literacy around technology and the fluency on the user end, not only on the patient end, but also on the provider end as well, because remember, it was new to providers, or it is new to providers. And then, JK mentioned some of the language barriers, and seeing that there's some differences in show rates, including on the telehealth office visits. And so, one of the complications that telehealth does is it makes it more challenging to conduct visits with non-English speakers if you don't speak that language. And so making sure that telehealth platforms actually have the ability to incorporate translators readily is going to be something important. And then there were privacy concerns as well. Some of this is tied back to technology literacy, knowing that especially early on, knowing you could put up a false background behind yourself for Zoom. Patients were concerned. They didn't necessarily always want providers or strangers in their home, which is what using video technology would have equated to. And then also, when they're conducting that visit with the provider, they want to be secure. They want to be certain that the provider is actually in a confidential and private place. So if they see a family member walk behind a provider, then they're a little concerned that maybe this visit is not as private and confidential as it should be. And the other things we noted is that, maybe just as a telehealth utility may actually decrease in value as the care complexity and the social determinants actually elevate. That's something we're exploring a little bit more as we continue on with our qualitative and quantitative research. Next slide, please.
And what has been interesting is to see how health systems have put the burden on patients to advocate for their own care without necessarily giving them the tools needed. So when we tried to unpack how telehealth was rolled out, we've been interviewing not just the providers, but the administratives, the front desk staff, the MAs. And the narrative, the story that comes out of it is, hey, pandemic hits, we start calling everybody to cancel all appointments. And for patients who had really complex care needs, who was not emergency, right? You didn't have to come into the ED. It was, all right, we're going to cancel your appointment. Please call us back if the condition exacerbates, right? And what has happened really over this last year is we've got this data void now, where we know about patients who have reached out to us, but once they reached out to us and didn't get an appointment, we really don't know what happened to them. And those that never reached out remain in that black hole where we don't know what's going on.
And so that leads us to having implications for patients and family members and providers. One is that right now, none of us really knows the full scope of what can and cannot be done in a telehealth visit. So inside of medicine itself, that's an area of research. And when that research is done, it will be important that it's done and includes populations that are often in the exclusion arm of research. So especially Black and African American patients, Latinx patients, patients who are poor, undereducated. So there'll have to be an intentionality to that research. One of the other things that happens with telehealth visits is there's a removal of other people in the office, in the care chain. So the front desk and medical assistants, for example, those are people who are vital to what happens to patients, and they create some of the community and culture of care, and they're missing from a telehealth visit. And then frankly, the providers, we just lack the cognitive bandwidth to advocate for all of our patients. So thinking about how might we be able to do that, and putting in structures in the office, maybe more social work support or things like that, that will be able to help to remove the burden of self-advocacy from the patients and share it with the care team.
The interesting thing is we've been at this for about 2 months to 3 months now, and there's a lot more to come. This is the Center for Anti-Racist Research funding has been incredibly useful and powerful because it has allowed us to talk to people about intentionally thinking about how we design the care experience, right? So we're talking to staff. We still have a whole bunch of interviews at the community health centers that serve our patients, to talk to not just providers, but to the front desk staff, the administrative staff, in taking those lived experiences, connecting them to what the administrative data say, and then connecting that to clinical care data to see if we can unearth these patterns that explain maybe not how thoughtful we were about the pandemic, but really understand how we can make sure that it doesn't calcify, kind of to Stephen's point of let's not put in routines that continue to perpetuate barriers for people to receive care.
I'd just like to point out, just in closing, a couple of potential policy and practice implications, looking at some of this. 911 is accessible to everyone, no matter what kind of phone you have. And maybe we need to advocate for regulation that would have bandwidth available for all people for when they need to make hospital or medical video visits. There will need to be curriculum development in all the education for all of healthcare workers on how to properly use telehealth. And then in terms of instead of just treating diseases, but thinking about patients as a population, a payment structure that actually pays for care, maybe prospectively pays for care, like a capitated system, versus a structure that only pays for visits. That way we're less likely to quote unquote lose patients. Thank you for your time and attention today.
And thank you for that presentation. Up next, we have a presentation on how U.S. state anti-racist policies can mitigate economic precarity and improve health and well-being in the COVID-19 era. And bringing us that is Julia Raithman, Assistant Professor at Boston University School of Public Health.
Hello, thank you for the privilege of being here today. I will be presenting on anti-racist policies and economic precarity, both research and a fellowship program. And I'm grateful to Drs. Elaine Nsoezi, Jacob Bohr, and Paula Austin for co-leading this work. The premise of our work is that historical and modern day racist policies shape racial and ethnic disparities in the conditions in which people live, and that these have led to disparities in economic precarity during the COVID-19 pandemic. Specifically, historical racist policies like slavery, Jim Crow, and redlining are compounded by modern day racist policies like a low federal minimum wage, evicting families during a pandemic and unemployment crisis, and an unemployment insurance system that excludes more people than it includes. These policies have shaped enormous disparities in wealth in the neighborhoods and homes in which people live, in the schools that children attend, in the jobs that those children may have later in life, and in health conditions and health care. So food and housing insecurity during the COVID pandemic are a result of the system shaped by these policies. And reducing food and housing insecurity now and in the future requires changing these policies. As an example of how policies have shaped the context in which the COVID-19 pandemic hit, we can look to wealth disparities by race and ethnicity. This figure depicts 2019 median wealth, and you can see that white people have nearly 8 times more wealth than Black people, and more than 5 times more wealth than Latinx people. What this translates into is that many Black and Latinx families are living paycheck to paycheck and cannot afford to miss a paycheck due to something like a COVID-19 illness or to unemployment due to the global pandemic. It is policies that shaped vulnerability to food insufficiency, which is defined as not having enough food to eat in the past 7 days. The food insufficiency was high for everyone during the COVID-19 pandemic. It was especially high for Black and Latinx families, who were 2 to 3 times more likely than white families to report food insufficiency in February 2021. The numbers are even higher in households with children. These disparities are not new. This has always been the case. Black and Latinx families have always been more vulnerable to food insecurity, as we can see when we look to families ever reporting very low food security in 2019, when Black and Latinx families were also more vulnerable to it. And it is policies that shaped these vulnerabilities. And it's policies that we need to change these vulnerabilities. So we are urgently conducting anti-racist policy research to think about what policies we may change. We started with state minimum wage policies. Many states have the federal minimum wage, which is $7.25 an hour, or about $15,000 per year. And you can see that across the board, in states that have a $7.25 minimum wage, food insufficiency was higher during the pandemic between August and December 2020. But some states have increased their minimum wage to $8 to $10 or $10 to $12, and a couple of states have $12 or $13 minimum wage. And what we found is that having a minimum wage of $12 or $13 was associated with reduced food insufficiency among everyone, and especially among people who were Black. We also looked at paid sick leave. We found that people who did not have paid sick leave and who reported missing work because they had COVID-19 illness reported increased food insufficiency across the board. But we found that Black and Latinx people who had COVID-19 and who did not have paid sick leave had especially large increases in food insufficiency, suggesting that paid sick leave would be an anti-racist policy that would reduce food insufficiency. It could also potentially reduce COVID-19 transmission because people are put between, are forced to make a decision between missing work and risking food and housing insecurity, or risking transmitting COVID-19 if they haven't fully recovered. We sought to go beyond just conducting anti-racist policy research and to bring with us an anti-racism lens to academia, which we know also has an opportunity to improve thanks to scholars who've shared their stories in things like Black and the Ivory. We know that our students of color are less likely to report having a faculty mentor based on nationally representative data from the Strata Gallup poll, where 72% of white students reported having a faculty mentor, but just 47% of students of color reported having a faculty mentor. For PhD students, we see that this translates into fewer publication opportunities, which are essential for their success in academia. We also see that our students are affected by wealth disparities. These are nationally representative data from the Healthy Mind study. You can see that Latinx and Black students are more likely than white students to report worry about paying for school. And this may mean that Black and Latinx students are more likely to have to work while they pursue their degrees, which may make it harder for them to succeed in academia. So we started the Anti-Racist Research Student Policy Fellowship. We have weekly cohort meetings with 8 students and all faculty mentors. We have mentored anti-racist research studies with students leading publishable academic manuscripts. We have seminar and discussion series led by faculty members of color who are compensated for their time. We also compensate students for their time, which students have reported is very important for those who are of the lowest income, because otherwise they wouldn't have the opportunity to participate in such a fellowship. We also try to have a lot of humility to know that we have as much to learn from our students as they from us, and to constantly engage in discussion about how we can best support them. Our students are leading anti-racist research. Martha and Rashida are leading research on the public charge rule, which prohibits immigrants from benefiting from social support programs that have been essential to many during the pandemic. Olivia and Cheyenne are leading research on eviction freezes. Claudine and Doretti are leading research on unemployment insurance. And Jarlise and Alexandria are leading research on mask policies. And these students bring a different perspective than many faculty members to the work that they do. They bring lived experience with these policies pertaining to themselves and their families, and they ask more relevant questions and think of different solutions based on their lived experience. We have tried to facilitate widespread policy research of this type by collecting policy data at the COVID US State Policy Database, in case students watching today also want to lead anti-racist policy research. We also are inspired by the words of Dr. Kendi. He says that mentoring and educational programs can help individuals, but are bound to fail racial groups which are held back by bad policies. We know that ultimately it is the bad policies that need to change, and we see the mentorship program as an interim solution until they do. We also hope that these students will lead us in creating that change and in shaping a healthier and more equitable world. Thank you to the Center for Anti-Racist Research for funding our work.
Thank you so much. And now for our final presentation on the COVID Racial Data Tracker, we have Aviva Geiger-Schwartz, who's the data editor of the COVID Racial Data Tracker at Boston University Center for Anti-Racist Research.
Hello, thank you so much for having me. It's an honor to be here speaking to you today about our work over the past year collecting racial COVID-19 data with the COVID tracking project at the Atlantic. I will start with the COVID tracking project, which is a volunteer-driven initiative housed at the Atlantic. It was originally founded by a journalist, Alexis Madrigal, and a data scientist, Jeff Hammerbacher. It started in spring of 2020 in reaction to a lack of federal data on testing. And it grew over the course of the year to involve hundreds of volunteers from a large variety of professional backgrounds, myself included, coming from a public health and data analysis background. And this large group came together to address gaps in data from federal sources. Just to take you back in time to around the end of March, beginning of April, we were seeing the coronavirus outbreaks taking hold in the United States, and there was tremendous concern that these outbreaks could have disproportionate effects on our communities of color. There was also tremendous concern at the time over the total lack of any information about who the coronavirus was infecting, who was getting sick, who was being hospitalized, who was dying. And there was very little racial or ethnic data coming out at all at that time. And a series of essays appeared in the Atlantic over the course of the month of April from our own Dr. Kendi. I'll let you read his quote. But if we can see racist policies, if we can't see racist policies, we can't eliminate racist policies or replace them with anti-racist policies that protect equity and life. Despite the pressure from health equity advocates and including our congressional legislators, there continued to be a delay week after week going by with still no racial COVID-19 data coming out from any federal health agencies. And so in that context, a partnership was struck between the COVID Tracking Project and Dr. Kendi's group, which went on to become the Center for Anti-Racist Research here at Boston University. It was called the COVID Racial Data Tracker, and the data was made available and is still available today at covidtracking.com/race. The COVID Racial Data Tracker project involved a multidisciplinary effort. It included an advocacy arm that pushed states to release data under the thinking that the states were faster and more forthcoming with their racial COVID-19 data than the federal government was being. There was also an effort to systematically collect that state released data, standardize it, and analyze it. Now, the data collection process was conducted through the COVID Tracking Project. It involved a team of volunteers who were specially trained. They met virtually twice a week and collected data from each and every website and dashboard from every state. It involved scraping when possible, but in many cases, it was a meticulous process of hand data entry, checking and rechecking to ensure accuracy. And this very arduous process went on weekly through the 1-year anniversary of the COVID Tracking Project on March 7th of this year. A snapshot of what the data showed through March 7th at the end of data collection, we could see the indigenous peoples in our country were the groups most likely to contract COVID-19, with cases per 100,000 people highest in our Native Hawaiian and other Pacific Islander populations, as well as our American Indian, Alaska Native populations, followed closely by our Hispanic and Latinx populations as well. This picture with deaths was a little bit different in terms of lives lost per capita. We saw the greatest impacts on our Black and African Americans and our American Indian, Alaska Natives. And our data certainly had an impact. This slide was shared by Dr. Marcela Nunez-Smith, the COVID-19 Equity Task Force Chair under the new Biden administration. She shared this slide just a week after the Biden administration took office at the White House press briefing of the Biden administration's new COVID-19 response team on January 27th. And she used our COVID Racial Data Tracker data to illustrate her point on COVID-19 inequities rather than data from any federal government source. Now, our data certainly provides some important insights. When we look at the data nationally, it looks deceptively clean, you could say. When you drill down to the state level tables, you can start to see some of the issues and limitations with this method of trying to bring together publicly released data from 50 different state sources. So here I'm showing you the state level table from Alabama, only because it's first in the nation alphabetically, not to pick on Alabama in any way. Many of the issues that you can see on this table were found across numerous different states. The first big issue that we encountered throughout the data collection process was simply missing data. We would ideally want these numbers to be as close as possible to 100%, and they were substantially lower in many states, particularly with the racial data pertaining to cases. We found a tremendous amount of data was simply not collected and not available. We also had issues with 2 of our key outcome measures with no racial data whatsoever being released from many states on total tests and hospitalizations. Total tests, it turned out only 9 states in the nation released any racial data on this measure, and around half of the states ended up releasing any racial data around hospitalizations. By comparison, our cases and deaths data was much more complete, with all but one state reporting data for each of those two outcomes. And our last data that caused us so many headaches was a lack of standard race categories from one state to the next. These tables that we display on covidtracking.com show the standard census race categories, but many states reported their data differently. And in Alabama, for example, 3 of these race categories are simply not included in their data. And so they show up as zeros in this table. We had other states that would group race categories together in non-standard ways. Asian and Pacific Islander categories were often grouped together. And we also saw many states that would group their indigenous peoples together, sometimes with their multiracial individuals, and form larger categories called other race or all others. And anytime that happened, as a result, it led to our national totals, our total counts of cases and deaths occurring in these groups that were being aggregated to be substantially undercounted from what we can assume would be the true values. So where do we go from here? An anti-racist approach to public health data collection is fundamental before we can get to why racial disparities exist or what anti-racist policies should be put in place to do something about them. First, we simply need the data to know what is happening. And at a very basic level, data needs to be disaggregated by race and ethnicity as basic demographic variables, in addition to age and gender. To a great extent, that isn't currently happening, and it needs to be. It needs to be publicly available. It needs to be shared from a single, trusted, official national source. It needs to be updated fast. Data 5 or 6 weeks after an outbreak has already begun is of little to no use in terms of allocating resources and intervening with emerging racial disparities before they have a chance to take root and produce terribly disparate outcomes. And finally, the infrastructure needs to be there. I think I can speak for everyone involved in the COVID racial data tracker project and say that the very existence of our project and the COVID tracking project in general speaks to a general fundamental failure of public health data infrastructure in the United States. We're proud and we're so humbled to have been able to provide the service to our country at a time of need, but we turn to our policymakers now to study what went wrong, what solutions need to be put in place so that volunteer-driven initiatives are not needed in the future to address data gaps for any public health emergency going forward. Thank you so much.
And thank you so much, Aviva. And now is the time that I get to some of the questions that you've all been asking during this presentation to all of our panelists. We don't have much time and I want to get to them as soon as possible, as many of them as possible. But I want to start where Aviva was. Several of our participants asked about data with respect to AAPI communities. One asked, what does the data show for AAPI communities? Someone else asked, why aren't Asians including in some of the data comparisons between race and ethnicity? Another asked, are the exclusions because those results correlate with white results or because they're not researched at all? Anyone, Aviva can start and others can talk about getting that data on AAPI communities.
Right, we saw tremendous variability between Asian populations and our Native Hawaiian and other Pacific Islander populations. And we have reason to think that is barely scratching the surface in terms of the wide diversity in outcomes that would be seen if we had the data to look deeper into the sub-ethnicities within those broad categories. What is an AAPI community. That is an umbrella category that involves so many different groups with very, very different outcomes from one community to the next.
Anyone else have thoughts on that?
Yeah, I can speak for Children's Health Watch. I mean, in our data, we are collecting data in 5 hospitals across the US, and they happen to be hospitals that are not primarily serving the Asian community. And so while we do have some Asian families in our data set, they're pretty small numbers, so it's hard for us to break them out. But I think you know, some of the more recent work we've done, we've started to do some more descriptive work, and I think certainly in the descriptive piece, we can be breaking that out more. It's just hard once you get to sort of like the multivariable analysis to work with very small groups. But it's a really important point, and I'm glad that it was brought forward.
And
I think for us with the digital redlining, we actually paid close attention. We were trying to pay close attention to that in the CHCs that we tried to partner with. One of our CHCs is predominantly Black and African American in the demographic it serves. One is predominantly Latinx in the demographic it serves, and one is actually primarily, well, a third. So has a large proportion of AAPI, and then a fourth one is actually relatively mixed. So we were trying to bring that into the discussion, and some of it is now we're to the point of just getting adequate kind of enrollment from the various health centers. So if we get the data, we'll be able to use it, but getting it is a little bit more difficult than maybe we initially thought.
And that's one of the reasons we're looking at language too, right? English versus non-English speakers, because, and I think there was a narrative discussion going on in the chat about, well, not everybody who's an English speaker is a native English speaker is comfortable with American English. And that gets to some of the challenges with enabling patients to advocate for themselves and the challenges we're seeing with interpreter services. So it's something that I think all groups are pretty conscious about, but it's not something we've empiricized very well yet.
So another question is one related to one that I had, which is how do healthcare providers focus on actual race-based factors such as weathering, you know, the physical impact of racism that Black folks and other folks in America feel and how that affects their health, without getting into the idea of blame, where even health officials that we saw, like Dr. Fauci in the early months, would talk about comorbidities with Black people like diabetes or weight, without taking into effect that weathering. And we got a question that also asked, how do cultural differences in diet, self-care, and tailor to patient differences without appearing like they're using race-based medicine? How do you walk that line?
Yeah, I'll jump in. I think that in a lot of ways, we have to understand how much structures and those policy decisions result in people living in unhealthy places, right? And so, you know, we talk about kind of the maps that we all know. And I think that oftentimes people have less wealth and less health because of those places. And so equity becomes about what's the process of remediating, of repairing that damage. And so I think that more and more we assume that everything is treating the same when that's not the case. And so I think it's really important that when we start talking about weathering, it's not the individual's fault, it's the system and the structure that has made that a reality. And so we have to look to how do you change those structures. I think in a lot of ways, something just as simple as saying a stimulus check can't go to somebody who is an immigrant had huge implications in our research. And so we can therefore create an anti-racist policy because we know that often those decisions were made because of communities of color, of immigrants of color that were coming to this country.
I would love for Stephen to comment on the clinical aspect of this and the clinician perspective on it. But the narrative that I hear from providers when I talk to them is they don't necessarily see color. They're trying to treat the whole patient. but at the same time, we're not integrating all these disparate data sets. Megan talked about this idea of food deserts, right? When does a clinician ever see your home address and actually get a map that allows you to see, here's all the additional factors that you can take into clinical decision-making? We haven't gotten to that point yet where meaningful clinical decision support tools address these racial inequities in consistent and coherent ways. And
Well, I think that goes to some of that goes towards some of the curriculum development that happens in provider training. So it becomes a little bit more part of our thinking when we engage patients in the office. And at the same time, we have to address with each patient whatever the problems that patient in front of us has. So if you have diabetes or hypertension or other problems, the reality at that moment in time is that you have that problem, and we have to work with you to help to improve your health outcome. And when we zoom out, then we have to think about, well, why does such a large percentage of my population have this problem? And then we have to be able to put a systemic or structural approach to fixing that systemic problem that's there. So it's trying to work at an individual level with whoever's right in front of me at that moment in time, but then stepping out. And that's where the policy part of this that's what makes this policy part so important, is actually being able to take a collection of those individuals and then saying, wow, there's a theme here. What do we need to do structurally to address that theme that I'm seeing over and over?
So these questions get to the idea of community that we began with, that in a pandemic like this, you need community buy-in. One question is, how do we talk to those who are triggered by the mention of the word privilege to begin with? How do we go about creating structural change on large scales that require public approval? And another question is, how do we talk to those, sorry, I wrote that down wrong, but just essentially one problem on the one hand is among people of color, you have a lot of distrust of systems, but among people, those who are not people of color, there is often this rejection of the idea that race is playing a part, a natural defensiveness that goes up. How do you get over both of those barriers to get the kind of community buy-in that is required to address an issue like the COVID pandemic?
I think I'll take an initial stab at it, and it has to do is work that we've been doing with the Army to reduce stigma, right, to seeking mental health care. Good policy only works when there's good implementation. Right? Otherwise, it becomes motherhood and apple pie. And a lot of what you see right now is everybody talking a good game, nobody's implementing a good game. And that it starts with, yes, we will put policy out, but not only are we putting policy out, we're going to actually track progress over time. How many health systems are actually being held right now to their metrics on performance? Not a lot, primarily because, well, everybody's been given a pass for the pandemic. Stephen.
Anyone else wanna? All right, I want to get to a question that was alluded. Oh, go ahead.
No, I was just gonna say, I mean, that's like the $50 million question, right? But I think one, and this isn't the be all end all solution, but one piece of that puzzle is some of what Dr. Kendi was talking about, is helping people see their own self-interest in it, truthfully. And some of the work that my team's been doing, and we're certainly not alone, there are others around the country as well, of like costing, what it costs us not to invest. So like, what are we already paying for? And sort of putting it in economic terms of, you know, it's costing us $178 billion in 1 year to pay for the consequences, the health-related consequences of food insecurity. Well, surely, you know, we could use that money better. And so I think, again, this is not really getting to the piece about helping people really understand how their policies are racist, but it is helping people get to the, I'm going to support a different policy. And I think that has been an effective piece of the conversation to help people understand what it's costing us as a country to not act and not change.
And finally, I want to get to a question that I believe JK hinted at, but do we have insight into whether fear regarding citizenship status led to no-shows among some of the non-English speakers? And a related question on language proficiency deals with the fact that even English speakers may have a non-American accent or some other effect that makes it difficult for healthcare providers to understand them. What role does that play in just the 2 minutes or so we have left?
I'll just say in our Children's Health Watch research, public charge saw a huge change in people's uptake of public benefits, including SNAP and other things that we know are really health related. And so I do think that as we think about the othering of the immigrant and thinking about language as being a key component, I do think that even when people are eligible, the fear of it has huge implications. And so as we think about our communication, it's not just from the healthcare side, it is from the media, actually, in terms of many of the stories on public charge were in media in languages that were inaccurate, actually. And therefore, we feel like there are ways in which we need to unpack those racist policies and be able to make sure that people are aware of what they are legally entitled to. And I think that especially as we look at the new policies, child tax credits and other things, I think that how those get implemented will be the difference between whether those inequities get bigger or whether or not they get smaller.
Stephen was making a point earlier, and he can elaborate on this a lot more articulately than I can. But the challenge that you have with providing culturally competent care is not just the language factor, it's creating that context for care where the patient feels comfortable enough to talk to that provider without knowing anything is going to get violated or that somebody accidentally hears about it. So this idea of privacy preservation and not having to mediate their conversation without a trusted interpreter is a real challenge.
All right. Well, I thank you. Thank all of our panelists for joining us today for these really enlightening presentations. And I'm going to turn it back to Dean Galea for closing remarks.
Well, first of all, let me echo thank you to all our panelists. I learned enormously from all of you. And let me also thank Kim Atkins for wonderful moderation. And I wanted to thank the audience. I think somebody put a note in the chat that this is the most involved audience in chat they've seen for a long time. And I couldn't agree more. It's really, there are many, many things that I miss from in-person meetings, but one of the gains of Zoom meetings is this opportunity to see people react in real time. And I find like I learn from those comments as much as I learn also from the speakers. I want to say thank everybody for taking the time from their schedule. We realize everybody's busy, and to be able to be part of this kind of conversation is really a privilege. It really is one of the most wonderful things about being part of the academic world to try to advance these ideas. Thank you again to everybody. Thank you for joining us. Please join us tomorrow and the day after for parts 2 and part 3. Everybody stay well. Have a good evening.